Eric,
Omar.
how can you tell someone is prepping if they don't tell you that they're prepping? What are some of the first visible, audible signs? Like if you were to analyze someone, there's 4 people other than you on this call. How would you go about identifying the person prepping?
So we're talking cheekbones,
Okay.
jawbone, sunken eyes, neck atrophying, because it's the one thing bodybuilders don't know how to train, but they train everything else. So it shrinks in relation to the rest. And then just generally like your skull looking more prominent.
Yeah. And for that reason, you would pick whom out of the 4 of us? Like you're like, Omar, you got so much fat on your face, it can't be you. I'm like, fair enough, go on.
No, it's perfectly contoured. I mean,
Okay.
you still have, jaw and cheeks are strong on you no matter what.
Thank
And your skin stays smooth. You obviously take care of it, So
This guy.
But I mean, I just gotta say, it's Dr. Licameli in the house.
Yeah, I mean, and I really was feeling good about myself before that, but after those physical descriptions and then how it was clearly me who had all those attributes, I'm just ready to go on this podcast. So thank you so much.
I expect to see you wearing a turtleneck or a scarf from now on. As an insecure bodybuilder, we must cover up the small body parts. So, yeah.
Eric, and before we go on, because we have 2 other hunks here on the call with us for this monster episode, you noted this to me, and then retrospectively, I'm like, you are totally right. Nick isn't at that phase yet, but when we're podcasting, let's say you were 2 weeks out, so Nick has a good long while till he reaches that point. It was just the rate of eye blinks, where the conservation of energy it's like subconscious, but it happens. But I remember maybe, let's say 2 weeks out, Eric, it went from, just normal eye blinks. It was like,
yeah, where you think that the Skype is messed up and my FPS is too slow, and like that blink took a long time. Yeah, I mean, actually, if I'm going to be serious, Nick, you're at the point where you just look relatively normal. That's the highest compliment I can give you. There will be a point where you look like Skeletor, and that's when it's when people walk up to you on the street and like does this person know me? And they just kind of look concerned and they go, "Are you okay?" And yes, I've had that happen. Like you don't know me. You didn't even say hello. You're just concerned about my health from seeing me. That's when you know you're lean. That's when it's legit. But it's not just Nick Licameli who we have on the call today. We also have John Flagg and Jared Maynard joining us. And we are delighted to have these professionals join us. And I would love it if you could each introduce yourselves. Jared, we'll start with you since you are the other Canadian on the call. We're starting top down longitudinally when we look at a globe, okay? But not in terms necessarily of top down and which is the best country. I'll leave that for the viewer to decide. But we will start with you, Jared.
I do appreciate the fair stance you're taking. You had me until you just defined it wasn't in terms of like status. But longitudinal, that works too. But yeah, I'm Jared Maynard. I'm not the only Canadian on this podcast, and Omar, it feels really good. So thank you for that. Thank you both for having me on. I'm a physical therapist out here in Ontario, Canada. I'm a powerlifter, the owner of Unbreakable Strength, which is an online coaching company, particularly focused on powerlifters. And I spend a lot of time with the other bearded wonder, Mr. John Flagg, over here. So, John, tell us.
Well, I want to start by saying I believe in balance. And if people would be concerned about Nick walking down the street because of his level of leanness, I balance the show by people thinking, oh my God, is that fat ass going to have a heart attack? My vision of prepping is when you have a bunch of broken blood vessels by your eyeballs, maybe some blood on the nose, smell like ammonia, that kind of feel. But I'm a power lifter. My name is John Flagg. I own a company, Rebuild Stronger. We, very similarly to Jared, work with rehabbing strength athletes, strongman, weightlifting, powerlifting, back to the platform. Both of us have been affiliated with Clinical Athlete for a long time. And I am a certified athletic trainer, which some of you may or may not know. And an athletic trainer is another field of allied healthcare professionals. We focus on direct care to athletes. You see us mostly in like the high school and college setting, doing a lot of what you see physical therapists do in the general population, but focus mostly on scholastic athletics and that sort of thing. We've expanded beyond that, but that is our main role.
Awesome. Well, Jared, John, it's an honor to have you on, and this is an official message that goes out to Jordan Fagenbaum and Austin Baraki. We had to balance the scales. We had just too much barbell medicine on, and we needed to get clinical athlete back in the spotlight. Yeah. There's a dark side of the force, there's a light side of the force, and we aim to maintain the balance as the gray Jedi. So this is no offense to you, but can't just have you, okay? All right, so don't be offended, all right? So anyway, Nick, I want to give a big shout out and appreciation to you for setting up this episode, hooking us up with these fine professional gentlemen. And today, you can see this as a companion episode and an expansion of the topics what we had previously. Nick, is this your third time on?
I think it's my fourth.
So we had BFR.
And then there was the one with Quinn and Sam.
That's right.
And then Jordan.
That's right. This is your fourth time on. Congratulations. That's a big deal. There's only a small number of Hallowed Hall guests who have been on Iron Culture 4 times. So yeah, much appreciated. And yes, this will be a companion episode to those prior episodes, except for the BFR one. That one stands on its own, where we're going to be talking about how the field, and correct me if I'm wrong here, the field of treating injuries, and especially in athletic sense for the context of who we got on and our listeners, maybe some of the, as you said, John, I love this term. What was it? Faulty movement paradigms. Yeah? So I think there is still a lot of focus on specific diagnostic criteria, testing, and assessing changes that have some potential issues with them. And it would be really good to have a robust discussion around that, because I think some of this stuff is opaque if you're not well-versed in these topics and practicing in the area, because you can assess a change. You can assess something that seems like it should be related to human movement and potentially impacted by injury. And then you can also put an intervention forth as a practitioner and see a change and measure it. And that all sounds super legit, and probably even in some contexts, there's nothing wrong with that, but it is potentially the narrative that goes behind it, and some of the side effects from it, and some of the not understanding the assumptions that are baked into when you do that, that I think are the issues. So Nick, I'm going to let you take it away from here. Can you introduce what this roundtable is about in probably a better way than my non-expert mouth can?
Sure. Yeah, and just thank you guys again for allowing me to be here for a fourth time. Stronger by Science podcast is my favorite podcast to be on, and I just really appreciate the opportunity. So basically, yeah, I think that was a good introduction to this topic. Has to do with this idea of using different screens or tests and measures that don't necessarily have reliability, which means they can't be repeated, or validity, which means that they don't test what they're supposed to test. So we use these arbitrary tested measures to come up with some kind of impairment or dysfunction. And then we stack on top of that treatments, quote unquote, that haven't been shown to be effective to solve or cure the problems that we found out from a test that shouldn't be finding out problems in the first place. And then we retest after we give our intervention, and then we don't have any way to retest that other than something like our eye or our biases getting thrown into the way that we retest it. So basically, sometimes we see this idea of an arbitrary test coming up with arbitrary dysfunctions, treated with arbitrary treatments, and then retested with arbitrary ways to retest things. And sometimes it may seem like it works, like something has been cured, but when it comes to the world of pain, injury, and the management of those things, there are a lot of different factors that can contribute to someone feeling better, or someone feeling less tight or less restricted, or the ability to get into a deep squat more comfortably. There are many, many factors that can contribute to that. So I think sometimes we get results, but not because of the reasons that we think. And I think that's the crux of it. I think it's the narrative that comes along with it. And let's face it, this isn't cancer research that we're talking about, where we can just, if we say something works because of a certain reason, but it doesn't, oh well, like either someone's going to have less pain or more pain. This is not like something like life or death. This type of system that I'm talking about would never last in something like cancer research, where the stakes are so high. So I just think that's probably a good way to start the conversation. And then, we can probably take that and anywhere you guys want to go.
2 comments, and Omar, one of these is serious. Actually, not neither one is, I'll be honest. The first one is, I don't know why Nick hates capitalism so much. This sounds like an opportunity where I've identified and created a need for a product. I've supplied the product, and then I've given you an objective way. And by objective, I mean subjective, of determining if you still need more of that product. And the second question is do you need us to hide your identity from the Grey Cook hit squad?
Oh, wow.
So I just...
And Eric, I don't want to derail this any further, gents. But
That's
I have
all
a third,
I'm doing.
But Eric, I have a third question, and that is, how does everyone in this conversation feel about BDSM? Because we know that pain in general, pain isn't necessarily always even a bad thing. As I don't know if you folks were fortunate enough to listen to my pain science roundtable on my YouTube channel, but that was one of the first points brought up that I don't think was accurately defined. So that's, maybe we circle back. Like, Nick, that was a fantastic overview. Questions in the back of myself and Eric's minds that I'm sure we'll get to.
And to be clear, that's the body dysfunction something movements, screen of movements. It's actually not what you were thinking. This is
Eric,
a family first podcast.
No, John's a powerlifter, bro. Bench, deadlift, squat, military press.
I get it. Apologies. So yeah, that's important. Yeah, because there's the FMS screen, and there's also the body dysfunction screen of movement. And then there's also bench, deadlift, squat, military press. So I think people can get it twisted when we're talking about pain and the term BDSM comes up. Yeah. So that's fair enough.
They get put in a pretzel, yeah. Exactly.
So I guess my first question is, and it's a combative one because that's fun, is Nick, if I'm a practitioner and you tell me that I have this screening tool and it seems to relate to the issue my client is having, and I intervene, I do something, and then I test it and it's better and their pain is lower, how can you say that I've done something wrong or this is a problem? Why are you throwing my toys in the trash? That is so. What is the issue? Like I said, that might be the knee-jerk reaction if I was a practitioner who had the experience of successfully using these screening tools. And I think sometimes it is frustrating in the evidence-based community where we get presented these ostensible tools of assessing something, then we can make decisions based upon it. And if we question the validity of that, it is the knee-jerk reaction to feel like, well, what do I do? And this is an experience I've had in multiple conferences that I've done around the world for the last many years. The very common, and this is more in the physiology sector, the Poliquin idea, where certain skin fold measurements are associated with specific issues that therefore have specific interventions that often result in just giving people fish oil. But the point is trainers felt like they had a tool, right? Mm-hmm. I can assess something, I can do something about it. And of course, when you manipulate nutrition or give someone a more or less proven supplement, and there's also placebo effect wrapped in, you see a positive effect. So can you talk about that a little bit?
Yeah, I think one of the things that you just said made me think of, I guess, where to start this is confidence goes a long way. So if someone comes in with their tool that they've been using and they come in and they like bang, 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 like we're going to check this, we're going to check this, notice this is what we're going to do, this is going to fix this, how do you feel? And the patient or athlete is kind of like, whoa, that was awesome. Like this guy knows what he's doing. This is like top of the line stuff. Like no one knows about this except me in this room right now. I feel great. Like that in and of itself can have the effect that we're looking for. But at the crux of it, I think back to your original question, the issue is not whether or not we can get people out of pain or whether or not we can make people feel less tightness or less restriction. It's how we're setting the foundation for those things or for longevity. So if you do some kind of test or measure and come out with some kind of diagnosis and then treat it and get success, now that plants a seed in the person's mind. And that now kind of steers the ship as to where things are going to go if things pop up in the future. And if that foundation is not on something solid, like solid principles, it's not going to work out well for that athlete or patient down the road. So I think that's kind of what it comes down to. It's that narrative. It's that planting of the seed of dependency, of making someone feel like they are broken or fragile, rather than saying, okay, we did this movement, you felt better. Let's just keep going and figure out what else works for you, rather than, okay, we did this movement, you feel better because now your tibias aren't rotating 5 degrees, they're rotating 3 degrees.
Gotcha. So I've got a question.
Can I jump in there, Eric?
Absolutely. I was going to ask actually the whole panel about their thoughts as well. So go for it.
So to make this a little bit more specific, because I don't care if the hit squad comes after me, you take the FMS as an example. You take it as a battery of movements, right? So if somebody comes into the clinic and they're like, hey, my neck hurts. Okay, cool. Let's take you through some active range of motion, some passive range of motion, see what hurts. All you've really uncovered there is what movement creates pain and discomfort. It's the secondary and tertiary claims after that become a real issue. It's saying, okay, cool. So this is what we know. We know that when you bring your chin down to your chest, it's painful. Let's do that a few times and see if the pain goes away. Because that's pretty much what you have in your holster at that point. Instead, it's taking an objective number and then claiming like, hey, if you score less than a 14, like you're going to spontaneously explode as you run down the court. Like that's just, when we extrapolate it to that distance and try to make a claim like that because capitalism, then now there's a problem. And that's where Nick starts talking about planting that seed. Now you have an athlete that may be fearful. Now you have a client that may be fearful, and they're saying, well, what do I got to do to get above a 14? Or, you have other people claim, hey, I watched videos of elite athletes in slow motion and I can see this small degree of change. And that means that if you do that, it's even 100 times worse, that your body's going to explode. It's that next claim, that next level claim that creates real damage.
Gotcha. So it sounds like there's nothing inherently wrong with movement screening or testing. It is, what do you do with that information and what emphasis do you place on it and what's the narrative around it? Is that, Jared, is that kind of how you see this?
100%. Because, you talked about what do I do? And when I'm thinking about situations like this, really first and foremost, I'm thinking about the people who are in pain or having some sort of problem and they're looking for help. There's always something that brings them in the doors of the clinic, or brings them to reach out to somebody because they're in a place where they probably don't want to be, or they want to get somewhere better. And usually the questions people have are, what's wrong with me? Am I going to be okay? What's it going to take? How much is it going to cost? How long is it going to take? And, how are we going to get there? So they're looking for answers. Understandably, anybody would in those situations. So it creates this vacuum, or I guess maybe the temptation to try to explain it really, really well, especially for people who are standing in the spot of a coach or a clinician, because person hurts, they don't like it, they want to get somewhere better. Tell me the answers, fix it. And that's the other side of it, especially with the clinical athlete side that Nick and John and I are involved in. Clinicians, they'll hear people like us or anybody else talk about these narratives that maybe mean well, but they're not really based on a whole lot, can't really be verified or not objective or whatever it is. And the question is, well, shit, I've still got the person coming in on Monday. What am I going to tell them? So anyway, bring it back to what you said there, Eric. 100%, there's nothing inherently wrong with movement screens. I just think it's really important to limit our explanations to what we actually know. And going back to what Nick said, confidence goes a really long way, and it can kind of cut both ways. A quote that I love from Derek Miles over at Barbell Medicine, I think he got it from somewhere else, is always confident but never sure. Where you can speak to uncertainty, like, hey, cool, yeah, we got a bunch of stuff going on, a couple possibilities. But you can say that confidently, and you can reassure someone, hey, you're going to be okay. People go through this a lot. I've worked with people like you, and I know where you want to go. Here's how I think we'll do that together. How does that sound? And then you co-create that journey. So that was a long tangential answer, but that's what I think.
I think it's a helpful perspective because having been an athlete who has been injured and having, anyone who's had any experience with medical issues, there is sometimes, maybe you haven't had this experience, but I've had the experience where I am afraid because of the unknown. I don't know what this means. Will this limit my athletic career? Will this limit my functionality? Will I be in pain permanently? Is this going to fundamentally change my life? And there is a strong drive to obsessively try to figure out what is the cause. This is what gets people in trouble when they start Googling symptoms, and then the next thing they know, they're calling the emergency room. And I have been there, and I get it. And even as a relatively educated person, a PhD in sports science, equivalent to at least half a bachelor's in most soft science fields. So if I've been there, I know that other people have, and I can understand. I'm putting that pressure on the practitioner. I'm directly asking you, I need an answer. And there is a difference, like you were elucidating there, Jared, between saying, oh, I don't know, I don't have the data, which kind of leads you to feel like, oh, this person's incompetent or something weird is wrong with me. I need to get a second opinion. Nobody knows what's wrong with me. This is a huge issue, which isn't helpful. But there is an equally unhelpful and potentially even less helpful answer of giving them something that is kind of half-cocked, and especially if it has a kind of a narrative of you're broken, or the person could elucidate, or they could interpret that even if you don't mean it. Now you've confirmed their worst fear, right? They went from being the unknown to, oh, now I'm a back pain person, or now I'm a busted neck person, and that can limit them needlessly. So it sounds like there's a fine line to walk, and this isn't just about the scientific reliability and validity of these tools, but more so, or equally so, it is about your quote unquote bedside manner, and how do I accurately display what we do and don't know, but also leave open the possibilities of where we can go, and then also put this in context. This is not the end of the world, et cetera, like you said. So I think that's a really helpful perspective.
Can I jump in again on that?
This is your place to jump. Yeah.
Oh, I feel so welcomed. 100% in terms of the unknown, and I've gone through that myself. Sean likes to joke that with all the connections and organizations we're a part of, we've got a cool incestuous relationship, and I'm going to let you all in. So I hope you all want to bond, because it's about to happen.
Big fans of incest here on Iron Cultural. Yeah.
I knew I felt at home for a reason. So I had a pretty nasty hamstring injury back in 2015. I was fresh out of PT school. It was a random day in the gym. I was deadlifting sumo, so I was cheating, but it was nothing crazy. And just high hamstring on my left side, felt like it was tearing. And I did a quick check on myself because I was a newly minted PT. I should be able to figure this out. It took a long time, and it really limited my ability to train. And talk about identity. You hit on that, Eric, in terms of I'm a low back now. I've got a problem there. Not even to mention our identities as bodybuilders, powerlifters, whatever it is that we do, athletes in general. So it was really hindering me. And Quinn, we've had on, he was the guy that I reached out to first to help me out with this. And I distinctly remember one of our consults where I talked about just my identity as like, I'm just a hamstring now, or I've got a hamstring injury, or I named it something stupid. And he's like, don't do that. And it was the uncertainty, because we didn't know how long it was going to take. Quinn gave me his best guesses, but really it came back down around to, as you mentioned, the context of the situation. It was the reassurance that, like, yeah, we can handle this. It sucks. And it was the the acceptance and the space to just kind of feel that and just curse and swear and say, like, this fucking sucks. I hope you guys are cool with cursing. So it was that, and then also bringing back around to this place where we could tackle it together, because uncertainty sucks, but it sucks more when you feel like you're alone. When you've got someone who's walking with you, it's a little easier to manage than when you have a semblance of a plan or a framework. It doesn't necessarily have all the answers, but you have a sense of how you're going to handle the curveballs when they come up. Makes it easier.
Gotcha.
Like Anna and Elsa walking into the unknown. I had to do it.
See,
We've
you're a
said
dad.
into the unknown way too many times. Frozen 2 is just rapping in my head right now.
Dad points for you. Good job.
Go.
I should say that the three of us, are fathers to girls. So Frozen is something that we've all experienced multiple times.
PR deadlifts to Moana. That's where it's at.
Yeah.
I'm telling you. I am Moana, like right as you're about to initiate your pull, 10% increase.
I'm writing that down.
Yeah. That is fascinating because Eric and myself, when we said incestuous, it's more like we're brother lovers. It's kind of like the classical, like, Greco-Roman references to the pantheon of gods, where there's intermingling, there's an understanding, there's multiple forms of bonds. You know, in the Greek language, there's many different actually adjectives to describe love. And we encompass basically all of them. I do, Eric, want to hop on, though, for a second, just to echo what Jared said and what you said about injuries. I'll never forget this. One of the worst bedside manner experiences didn't happen to me. It happened to my brother over a decade ago. We're throwing some pigskin. We're just throwing a football around. And so, full disclosure, my brother's a musician. He plays guitar. And so I threw the football. He caught it, jammed his finger. No problem. It looks like a Z. And so we're laughing. We're like, this is over a decade ago. We're like, just like 20-year-olds. We're like, all right, we'll go. Hey, we live in Canada, Jared. We're going to go to the emergency room. No problem. Free healthcare. Boom. So we go there. We're laughing, having a good time. Up until this point in time, like, we're laughing, like, man, that figure looks jacked up. But, you know, we're great realistic expectations. It wasn't the practitioner that we saw. It was waiting inside the emergency room. This person was disagreeable. This person was not having a great day, inebriated. And the guy said, "Bud, what are you in here for?" And my brother's like, "Oh yeah, you know, I jammed my finger." And he looked at it, he's like, "Oh yeah, no, that's gone." And he's like, that finger's fucked. He's like, "No, I came in here." He's like, "No," he said that, like, out of nowhere. It was a relatively empty day. But John, he's like, "Oh no, I see that. No, I came in here before and they couldn't fix it right. They actually broke it even worse." And then we're just sitting there because it's like 2 hours of waiting. This guy out of nowhere, right? And we're like 20-year-olds. First time it happened. I looked it up quickly when we got home. Seems fairly simple, right? So our expectations were cool as cucumbers. And then this guy out of nowhere, he went on a rant and this and that. And then he went how, like, the government's trying to take theirs, like, just a bunch of stuff. I'm like, okay, cool story. So we spent there for 2 hours. It's fine. But it went from, like, we're cool to, like, oh boy, to me actually fearing then for my brother's career as a musician, because I'm like, okay, like, this is one of his fretting fingers, like one of the main ones. And that could just show the inversion that happens very quickly within a matter of hours. And then, of course, you see the doctor and the doctor's fine. They're like, yeah, don't worry about it. Give it a few weeks. And then you have, as you said, Jared, the agony of waiting, which I think was painful for my brother, where, again, cool, had that incident. Doctor seemed confident, but you still have to wait the 3 to 4 weeks before you see the end outcome. So it went from being relatively certain and fine to, like, some of that wrench being thrown in just by, like, one voice as one example. So I could 100% for people to experience these things, and then you relate your identity to that 100%, man.
Well, think about what Jared said earlier too about confidence. This is one of the things that we see with a lot of clinicians where it isn't a big deal, and then we kind of blow it off. So you just had this guy, like, rant and rave and tell you all this stuff and, like, oh, you're never going to play a D chord again. And the next thing you know, you have a doctor that's like, oh, it's going to be fine. You're cool. It's whatever. Don't worry about it. Which one are you actually going to take more seriously in that experience and remember?
Sure.
And that actually becomes a huge factor. We talk about these movement screens and systems and that sort of thing. It gives people confidence to actually say, oh, no, it's this. And then the person experiencing that says, oh, they know what the fuck they're talking about. Okay, cool. So now the experience shifts, and there's a lot of power behind that, as opposed to what is truly the answer, which, I mean, I'm hopefully your brother's still playing guitar. It probably wasn't that big of a deal. You know, give it a good stiff pull, tie it, tape them together, throw some ice on it, go home, chill out, you know, you'll be fine. But it's that experience that actually changes the narrative too, and that confidence that some of these things bring with their claims that suck people in and get that narrative going.
I love it.
Yeah, I think what I take from that story is that person in the waiting room is the same thing as the fire hose of information that patients and athletes get hit with the internet, whether it's social media, Google. Because if I have back pain, chances are I'm not going to go to a physical therapist without first looking things up about back pain. And so they come to us already with that defeated mindset, already with a diagnosis and a prognosis. Like, look, I know I got a herniated disc. I feel this, I feel that. Like, I was putting my shoes on the other day, and like I swear I felt the disc like pushing out a little bit on like my nerve. And the first step for us is like, look, like totally understand like what you're talking about, and you're right. Like the disc is in the spine like that, and the nerves run very close to it. However, and then as that conversation just starts, how we're not Toyota Camrys where things just kind of move like machines, and then we get into the conversation of pain and maybe how asymptomatic people can have disc bulges and herniations, and just kind of tiptoeing around that conversation just to kind of talk them off that ledge first. Because if we just dive in with our treatments and screens before addressing that, nothing is going to work. So I think that person in the waiting room, just like you guys felt yourself, like, oh my goodness, like it's just have that feeling in your stomach, like, oh, this could be bad. That's what we're getting when patients walk in the door.
I love how Nick just equated that guy to a Facebook feed.
Yep. And
like catastrophizing and the housing market's going down and it's all bad.
And I have two comments on that. One, you can trust a man when he has humility, because it means that he is constantly questioning his own beliefs and learning new things. And what is more humble when you're ascribing yourself to be like a vehicle, and you could choose any car. And what do you go with? A Toyota Camry. And I guarantee you Nick was not thinking of a new one either. He's probably talking like a 06 at best. So you can trust this man, gentlemen. And for everyone who is already on board and trusting people, just like John said for that finger, we're just giving you a stiff pull. You're appreciating this. It's something that you're already on board with. But for all the people who are not ready for John to give a stiff pull to, I think we need to talk about maybe some of the underlying things. The people who are kind of going, hold the phone here. So one of the underlying concepts here that we discussed, or the underlying belief that makes all of this relevant, was that something like a FMS or a different type of movement screen is not valid and is not reliable, right? So let's unpack that a little bit. Supposedly, function and form are somewhat related. And if there is some type of structural injury or damage, that would potentially impact our movement. So why is it that something like a movement screen can't be used in the way that maybe we're suggesting it shouldn't be moved? Let's talk about that. Why is a good functional movement screen, one of the many ones out there, not a tool to be used in this manner? Who wants to get the gray? Who wants to go against the legions of Cook?
We're all in this together. I just want the Camry to lead the way.
We'll follow right behind you, Nick. Yeah.
As soon as the car starts up.
So, I mean, I think what it comes down to is if we're going to test something, we have to make sure that's going to change what we do. Otherwise, why are we going to test it, right? We don't want to instill that sense of fear unless we know for sure that it's going to lead to something detrimental. So if someone has a tumor growing out of their head, we want to instill some fear in that person. We want to instill urgency and then encourage them to get treatment. What we don't have in something like the FMS is that. So we are just instilling that fear, instilling that fragility in that person without any meat behind it, without any proof that that's actually going to happen. So something like movement, something like pain, like we talked about, is so multifactorial that, I mean, we can't even describe an injury in the research consistently. So if we're trying to predict injury with something like a functional test, is that taking a helmet to the knee in a football game? Is that rolling your ankle? Is that slipping on wet turf and pulling a hamstring? There are so many things that can happen with injury. Another thing is the military. The FMS has been used a lot in the military. How many ways can someone in the military get hurt? That doesn't involve whether or not they could do a hurdle step in the FMS. So I think the problem, and to answer Eric, to answer your question, is that we don't have a set of movements that can really encompass everything. And I don't know if that's the fault of the test. I just don't think it can do what it's supposed to do, or what some people claim that it does. So I think that's part of it, is that it's so multifactorial. Injury is such a gray, murky area already. So how can we predict something or reduce the risk of something if we can't even nail it down in the first place? And then what happens, and another thing that kind of grinds my gears a lot with these type of screens, is not just the FMS, but just the narrative that, like the naturalistic fallacy of, hey, like our ancient ancestors never wore cushioned sneakers. So wearing a sneaker that feels comfortable for your foot is really going to be detrimental to the health of your feet. And everything starts at the feet. So that's going to cause problems upstream in the rest of your body. And again, it's like the FMS, but it's just in different context, right? So we're instilling these beliefs in people, that we shouldn't be, because why are we first, a little bit of a rant with the whole ancestor thing. Why are we holding up our ancient ancestors on this pedestal as if they had it right? If they came into our time and they saw a chair, like a cushioned chair, they would think it was the greatest thing ever. Like they wouldn't fear it. Like they would, oh my God, like I've been walking for 4 days. My back is killing me. Like I have this cushiony chair now to sit in. And then we also would hear like, oh, well, the prevalence of back pain or knee pain is getting more and more now than it was in the past. Well, yeah, that's because when someone is struggling to feed their family and not get eaten or not die of hypothermia in the wintertime, they're not thinking about their patella femoral pain that they're having because they have other problems to deal with. So I think part of the reason why we kind of get a bad rap of like living in this time is because we have it so good. And so if we're having pain, it's got to be because we've drifted too far away from our ancestors. And this goes with nutrition, right? The nutrition side of things. Like, I mean, you've had episodes on the carnivore diet, and so it kind of goes.
I don't remember that one.
That's right. But I'm gonna stop. I'm gonna pull back there. But the naturalistic fallacy is something that we see often, and it's one of those things where when it's mentioned, the patient or athlete is always just like, oh yeah, that makes sense. It makes sense. Like our ancient ancestors like didn't do this, so we're not meant to do that. But we're different. Like we're so different, and we can't just talk about something like the way that we sit or the way that we walk, and not talk about the fact that we wear clothes on our skin 24/7, or we go from 0 degree weather outside and walk into a room that's 70 degrees in a split second. There's just so many differences between us and our ancestors. And I think we probably have it best now than we ever had in the history of mankind. But I'll leave it there. Someone else take the mic.
I agree with you, Nick. If our ancestors were somehow teleported here, they would be amazed. They would also immediately draft Omar because he walks the walk with the ancient workouts and he can hang. Just had to throw that in there.
My man.
Well, it's very similar, right? It's very similar to this idealistic way that we view Spartans, right? Because of 300 or because of any other movie that we've seen with Spartans in it. We think that they're jacked, they're ripped, they're these big, tough guys. But then like Omar has talked about multiple times, they're probably more like endurance athletes, right? So I think sometimes we need that little reality check. If we're going to be comparing ourselves to something, we got to make sure that like we're going to the right place for advice on how to live a healthy life.
And I'll jump in and bringing it back to the movement screens. Part of what makes this difficult are a few things. One, like Nick touched on, is even in literature, like in terms of the word pain, there are updates to the definition of what that even means on a fairly regular basis. Same for the word injury. So there's some vagueness there. And then in terms of what the research tells us about these screens, we got to question how much transference there is when you look at hurdle step or an overhead squat, dependent on who we're working with. Who's the person in front of us? Is this a power lifter who's trying to sumo deadlift, 700 plus pounds? Is this a field sport athlete who needs to cut and do different things? Because what the research seems to say is that if you get better at an overhead squat in the FMS, and we keep coming back to it because it's a pretty relevant example, you get better overhead squatting. But does that necessarily mean that you get better at pulling your deadlift or cutting on the field? And that doesn't seem to be present. The other thing is we know, like we come back to principles. We know physiologically certain things tend to be true. We've got a range of values that we're looking for in terms of, say, range of motion for joints. We know, if we know what you're trying to do or what someone is trying to accomplish in the gym, on the field, on the court, whatever, we can picture what that looks like and we can then break it down. What do you need to be able to do? What positions do you need to get into? What forces are acting on your body? How do we get you from where you currently are to where you want to be so you can do the thing you care about? And we understand that fairly well in terms of the exercise physiology and the physics of it all. So I think that we get better return on investment, and we're less susceptible to these narratives that sound kind of cool and maybe get some clicks and like engagement on social media and make people want to come talk to you and work with you, and get better results in terms of getting people where they want to go if we stick to those principles and we don't try to explain shit that we don't maybe really understand all that well, and focus instead on who's this person, what's their story, what do they care about, how do we get them where they want to go. Yeah, I just think we can cut through a bunch of the bullshit, really.
John.
So for me, when it comes to this, what I see a lot is a lack of data control. And Nick kind of mentioned it earlier, and I love how he brings up the naturalistic fallacy, because Nick, 150 years ago, nobody actually died of cancer. Nobody did. None of them. They just died. We didn't collect that data. We didn't have it. So you see people do this in multiple different realms of disease. It's like, 50 years ago, nobody had that. Yeah, because we didn't even know what it was. So in data for this, right, Nick mentioned like the military. Well, you can get shot. You can get your leg blown off. I have a friend. He got his leg blown off. But they linked in like concussion, contact ACL injury, contusion, like contact shoulder dislocation, all as registered injuries for a movement screen that you don't have somebody hurtling at you at 20 miles an hour. Like DK Metcalf isn't chasing you while you're doing the FMS or doing some of these other screens. So it's not valid within that. The second big limitation for me, and Eric, I know you're just going to get super sized for this, man. Motor learning isn't attributed to anything in this. So raise your hand if you followed Omar's learning curve for Olympic weightlifting, because I know I sure did. And who remembers that first attempt at a snatch as super cringe?
Omar definitely does.
Oh, yeah.
But the thing is we don't, you look at something like the overhead squat as a learnable skill and something that with each repeated test, they get better at. Your brain is really, really good at getting efficient at things you have it do repeatedly. And I know a lot of people are like, oh, well, you're supposed to do these tests far apart from each other. But test retest happens. And even though that first exposure, the expectation of the test, the remembrance of the test, the remembrance of when you explained the test last time and what their score was, or whatever that may be, is all going to be there. And that repeated effort creates a skill acquisition phase where people are just going to get better at it. You can have, even with something as simple as like somebody with limited shoulder range of motion, you can increase shoulder range of motion with just 3 runs through active range of motion. That's as high as my arm goes up, by the way, guys. That's it. So in these tests, we don't take any skill acquisition into account, and that's a huge limitation because you can't just remove the brain. The brain is an incredible, complex thing that learns on the fly, automates processes, gets as efficient as possible, and you can't take it out and just say, okay, go through these arbitrary movements and I'm going to attach some injury risk to you. It's just not how it works.
Well said. And I'm going to bring my typically unhelpful doctorate to this discussion that might help us generally understand some things about reliability and validity. Which just for those who are listening who don't know, reliability basically is a concept of if I repeat the test, do I get similar scores? And there are different forms of reliability. There's intra and inter-day, and there's inter-rater reliability that are probably the most relevant to something like a movement screen. So if myself and Susie are both trained on doing FMS screens and we both test the same person, will we get the same score? And if we test that same person on different days, will we get the same score? And that is going to collect a bunch of different sources of error. So if I did on Monday, I tested this person, just like John was saying, now they've been exposed to the test. Now, if Susie tests the next day, not only will she might administer the test differently than me and have a different skill set and being able to interpret scores, but the person is now in a different state on that next day. So there's biological variation, and then there's also the learning effect. So the scores we get, how similar are they? And my read of the literature on movement screens, and I'll admit I haven't looked at this recently, so this might be a couple years old, but my general take when I remember kind of just assessing this broadly, looking at some of the systematic reviews and meta-analyses, if I wanted to steel man the FMS specifically, it's that it can be reliable. The FMS can be done in a way where you can get people to have a pretty good reliability. Of course, you're still going to get that learning effect. So if you have someone who is like quote unquote well-trained on the FMS, you'll get a score. And there at best might be a cutoff, like where if you have a really low score, that might predict injury. Not super strong, but what there is not is the validity aspect. So I talked about reliability. So what validity is simply saying, does this represent something else? And the typical way you actually do a validity test on something is you have your gold standard criterion measure, which gets the closest you can to empirically and objectively assessing a thing, and it has quote unquote face validity. As an example, the only way to actually know how much adipose tissue there is in a human being is to dissect them and weigh it. So the criterion for body composition is something currently like DEXA, because we think it's the best proxy we have where we're actually doing some imaging. And then if that's the criterion, then I'm going to do skin fold assessments or bioelectrical impedance or a dunk tank. And I'm going to see how much do those agree. And we can actually do an agreement test, typically the Bland-Altman. So with FMS, okay, what are we using this for? The idea is that for a change in the FMS score, there should be a detectable change in the occurrence of injury. And that is what there is not. There might be a cutoff saying like, yeah, if you can barely move at all and you try to do sports, you might get hurt more often. Like if your score is really, really bad on the FMS. But what doesn't happen is changes in the FMS or a kind of a ranking predicting injury. So there are some big questions as to the validity of this scale. And I think that probably speaks to all the multifactored elements that we all talked about here. And that, I think, reasonably would apply to pretty much any movement screen that you can think of. Because I think human movement is just far more complex. And injury, like you guys said, is far more complex, multifaceted, and there are disagreements on terminology. So anyway, that's my little input. Nick, I know you wanted to say some other things, but I'll leave it there just to make sure the audience is keeping up.
Yeah, I think I just wanted to kind of piggyback off of that, of what you just said, Eric and John. I think one of the problems is when these things are created, and not just the FMS, but even just like measuring someone's posture or assessing someone's posture, or someone's ability to bend down and touch their toes. I remember like in elementary school, that was one of the tests, right? You have to sit and reach past your toes. And if you can't reach past your toes, you get points off of your score. these type of things, it's almost like we create the test first and then try to search and see if we can find a problem that it could test. And so if we think about something like, I used cancer before as an example, but if someone gets a blood test and they find a certain type of pathogen in their blood, we are sure that that test is going to accurately identify what that pathogen is. We take that result of that test, and Eric, to your point, if we do that test every day for 30 days, we're going to get the same result 30 days, whether you do it, whether Susie does it, whether the person has had the test once or 30 times. We take that result, and then so we know that we have a treatment. It is all hypothetical, right? We know that we have a treatment for that pathogen that test found, and so we know that we can educate the patient. This is what we found. This is what we know is going to solve that problem. You're going to take this in this certain dosage, right? So now this is the treatment that we're going to do. We're going to take it 2 times a day for 1 week, and the pathogen should be taken care of, right? That is what we don't have in these systems that we're talking about. We try to make it like that. I think we're trying to be diagnosticians, and we're trying to treat these problems, but we're just not there. And I don't think we'll ever get there. I don't think that should be the goal. And to John's point, when it comes to something like the overhead squat, you can get pretty darn good at an overhead squat. You can get really good at bending down and touching your toes. But if that's the goal, right? Like if that is the goal, because the narrative has been planted that if you can overhead squat with a dowel over your head, that's going to reduce injury risk, or that's going to help you become a better bodybuilder over time, or whatever kind of narrative you want to put. Now, the problem with that and the true danger is that now that athlete is focused on correcting the overhead squat, as opposed to doing their sport or gradually exposing themselves to their goal. Because if we don't ask what the goal is, why are we even giving them homework to do, right? To try to fix, because it has to be specific to the goal that they want to do. So I think that is the main problem and why this stuff is so serious. And like, I know a lot, we're joking around a lot, but at the end of the day, like I've worked with athletes from around the world, and so many times I see these young athletes come to me with just defeated mindsets, and they're focusing on the minutia because that is what's flashed before all of our eyes every single day, because it's the sexy headlines. It's the foot training. It's the specific exercises. It's who can come up with a crazier looking core exercise, because that is what's going to cure your back pain. And what it results in is too many people getting blinded from the principles of knowing your goal and modifying that activity to reduce the pain, so to calm down whatever you're dealing with, and then gradually work back into it. At the end of the day, that's what we're doing, right? I think it's Greg Lehman, right, guys? Calm stuff down, build stuff back up, right? At the end of the day, like, that's what we have to be doing at first. We have to be progressively loading these patients and athletes. But too many times, we get caught in the weeds, and that's the problem with too much information overload. It's hard to discern the gems from the poop. And that's the true problem, is that we're setting people up for failure because they are just drowning in information and don't know where to go. And they're trying different things, feeling more fragile, feeling more dependent, and they're trying to latch onto something for a bit of hope that they can do what they love to do, whether it's bodybuilding, weightlifting, running, playing football, playing soccer. And they're trying their best, putting their time and effort into it, but they're just using the wrong map to navigate the wrong path.
Yeah, I got to jump in on that too, because time is the one resource we can't manufacture any more of. This is the honest thing of it, right? So, Nick, I know you and I have similar experiences we shared where I distinctly remember as a younger athlete, still in PT school, would not start my workout because I didn't think that I could until I had done my regimen of foam rolling and banded warm-ups and whatever else was in my head as far as what I needed to achieve the proper positioning, make sure my pelvis wasn't rotated. I distinctly remember staring in the mirror, making sure it wasn't rotated, because God knows what happens if it rotates a little bit during a squat. You just explode, like everyone's seen on Instagram. So that's just it. For me, it comes down to making sure people don't feel trapped in, or like they have to put time towards something that doesn't give them the results they've been told that it'll yield necessarily. This is why context is not a sexy thing to talk about, but it's important, because maybe some of these drills or these screens hold some utility for some people. Great, that needs to be part of the conversation and at the forefront. And it does people a disservice when we make them think, however that happens, that they need to do X, Y, Z, otherwise they're at risk of injury. When we don't actually know that. We truly don't know that. And that's just not okay. And it's, this is another frustration I have in clinical circles, because a lot of these things have been memed. Like, people like to joke around about, the FMS, and you get your different camps that fire shots at each other, and it becomes kind of a jokey thing. The reality is that people who aren't necessarily part of those camps, who are just trying to figure out how to do the thing they care about, how to not get broken up, and make that work in the context of their lives, they're left thinking, what do I do? And that's why I think this conversation and ones like it are really important, and why we got to cut through the noise as best as possible, give people tools. And if they want to do some of those things, they want to get better at components of movement screen, or they want to foam roll mobility or do mobility drills, which I have nothing against, totally cool. But give them the choice. Don't make them feel like they have to when they really don't.
It's a perfect segue to, I think, the next component. 'Cause there's like 3 aspects to this roundtable, and one is what's the problem with screening? And I think we've done a really good job with talking about that and the narratives and even dovetailing off of that. And now, once someone has been screened, an intervention is put forth. And these range from reasonable to wacky, and I'm sure we can all think of them. But I think that's the place to talk about now is, what do we do? And maybe even we're doing this the quote unquote right way. We do a movement screen that tells us, like John, you said earlier, okay, when you do that with your head, when you incline your head, you have pain at this point in the range of motion. And even doing it multiple times, it doesn't just immediately go away. Okay, what's the next step? So I guess my question to the roundtable, and unless you wanted to say something, Nick, that kind of finishes off that last point, because I know I interrupted you there, is what are some of the treatments that are equally as problematic to the screens, and why?
Yeah, just one quick thought was that, like Jared said, it's not all of it is crazy hocus pocus, but I think what happens is the viewer gets caught up in the nuance. So maybe training barefoot, maybe it does improve the strength of your feet. But how many people out there are at the level and at the experience level where that is what they're focusing on, because they've optimized everything they possibly could. And now they can focus on, all right, you know what? I've been training for 20 years. I found my groove. Like, let me try some of this like minimalistic shoe stuff. Like, let me see if it does like change the way my feet kind of grip the floor a little bit, or diving into like deep biomechanics of like movement. Is it helpful to know? If you're at that level, maybe, but if you're just starting in the gym, or you're a novice or intermediate, man, there are so many other things that you could be focusing on than the exact angle of pull of the lats on a pull down. Like, we are not at that point yet, and I think those are the things that get highlighted too many times, and then so that kind of like Jared said, it kind of like misguides us. And the thing that, as I talk about this, I can't not mention the bro days of bodybuilding, because it's the same exact thing. It's the same exact thing about the post-workout window. It's the same exact thing that a sweet potato is going to change my physique versus a white potato. It's eating every 2 hours, right? It's all of these different things that we put so much weight into, and it changes our life. It changes the way that we perceive the world. Like Jared said, I had a very similar experience coming out of physical therapy school, and overanalyzing every single movement of from my toes to my knees to my hips to my back, and it's just very debilitating. And just like the bro days of bodybuilding, it's very handcuffed. And you, once you come out of that, once you educate yourself and you learn there's a better way, it's the most freeing feeling. And I think that's why we all exist here, whether it's bodybuilding, weightlifting, or pain and injury management. We've been there. We know what that feels like, and we know what it feels like to come out of it. And it's just such a freeing feeling. So treatments. Who wants to talk about treatments?
So I'm going to reference Quinn, my guy, my buddy. A lot of the times, what I see with athletes, with clients, is the approach, and I'm going to reference the great ballad of Ricky Bobby. It's like they got a knife in their leg, and they try to use another knife to get the knife out of their leg. Don't put that evil on me, Ricky Bobby. And what they do is you'll see them do drastically different exercises, or they'll completely rest the tissue itself or whatever injury they have going on and move into a completely different type of training. I see that with powerlifters quite a bit, where it's like, oh, I'll do CrossFit for a little bit. And instead, with a lot of soft tissue injuries, right? Like if you have a broken femur, just skip this part, right? But for a lot of soft tissue injuries that our audience is going to encounter, where you have a hamstring strain, or you have, some quad tendinopathy going on, or, old school jumper's knee that everybody talks about from squatting, spend some time in positions that actually suck at a tolerable level. It can literally be that simple. Continue to squat, continue to train with variations and ways to modulate your pain. It doesn't have to be a 10 out of 10 pain every day. You don't have to be, chewing your mouthpiece in half while you're lifting, but taking a tempered approach and continuing to go through the movements that you've ingrained well and have technique and skill in, so those don't degrade, while also going through ranges of motion that are going to be beneficial, are really good management tools in the very beginning. If they're not effective, now we can go down the rabbit hole a little bit and get a little bit more specific. I'm going to use like the knee as another example. Okay, so squatting is actually not something that's in the cards right now. Something like a step down, something like, God forbid, a quad extension. Like some of these older school approaches and isolation type movements are ways that you can modulate your pain and still get work in. Go there, do that thing. It's not until like, if you're beyond that part, then that's when we have to start really digging into like some tertiary stuff. But those two management structures right there can get, I would say, 90% of people out of the woods, and they can manage through those types of things. Is it going to be a straight line? No, neither is training though. Like all five of us here know there's dips in training. We talked about Nick's face earlier and his long neck because of his cut. Like if there's dips in performance, just like there's going to be dips in injury recovery. So know those are going to happen. Manage yourself through those the same way you would with training, and just know that the ups and downs are normal.
Yeah. For me, when it comes to problems and intervention, it comes largely when there's too much of a deviation. People scrap the plan or rewrite the plan more than maybe is necessary or warranted for where that person is. So another thing that gets crapped on a lot in clinical circles are modalities. I'm not going to say modalities don't have use. I think the same about modalities. And for people unfamiliar, I'm talking about things like heat or ice or TENS units or dry needling or acupuncture. Any of those things typically applied or done to somebody. I think the same about those as I do about movement screens. Where could they have utility? Sure. What are the mechanisms behind that? Different conversation, and we can go down that rabbit hole. But I think it's important to give people the choice if they want to use those things. If it adds value, if it helps them feel better, cool. Just make sure that we're representing that as honestly as we can, because there's not usually any voodoo going on behind them. And what I see, or what we see a lot in the clinical world, is chronic underloading or shifting too far away from the goal. Or again, whether it's in the gym or in some other setting, if we have that understanding of where that person's trying to go, and also, to get a little touchy-feely too, what that means for that person. We talked about identity before. It sucks majorly on a deep level when you can't do what you love to do, and you can't be part of the community that you're part of, or that you're part of. You guys talked about that with Mike T. That was a brilliant point. It really resonated. So being able to keep that person doing as much of the thing that they want to do, depending on what they can tolerate, comes with a bunch of benefits. One, the purely physiological stuff that we need in terms of handling more load or handling more rate of force development or whatever the thing. But then also, it tends to keep intact more of that identity. Like, okay, I can't do all the stuff I want to do the way I want to right now, but I can still do something with a barbell. I can still be in the gym. I can still be on the field. I don't have to stay at home or go to the clinic 3 times a week to do this really wonky list of exercises that look like they belong on an Instagram page, only to return to the gym Lord knows when. It doesn't make a lot of sense. And again, it robs people of time and agency as far as I'm concerned, really.
Let's talk about modalities, because I think that is unfortunately often the first port of call that I see, rather than something to experiment with, like you guys were explaining, when a close modulating pain movement pattern doesn't work. Because I think that's kind of the paradigm John was saying, is, hey, let's figure out what we can do and do more of that. And it could be as simple as just getting into the position where there's some pain, and hopefully that pain reduces and it gets to be more comfortable over time as you kind of gradually expose yourself to that stress. Instead of that being tried, that not working, and then let's experiment with some of these modalities that might at least have some underlying validity or seem to have some positive anecdotes behind them. What I often see is people go directly to foam rolling, or they go to someone and ask them, hey, can you crack my back? Or they go to someone and they say, hey, can you dry needle my X, Y, and Z? So I guess the question is, and I've always wondered this as a scientist, because I have been to physical therapists and physios who they've done that as one of the first things. There's an assessment, and then I get dry needled. And I always wonder, I ask them about, how does this work and what does it do? And sometimes they're able to give a reasonably physiologically sound answer. But even then, the description, I go like, how was that tested? Like, how did someone actually figure out that doing that does change the tissue in this way? I can't, maybe I'm just not, I'm not a medical doctor, so maybe I just don't know this field of study and how we can test to see if that underlying claim of how this works is actually what's happening. And then I think after that, like, okay, well, let's assume that was done. Then what are the next steps to actually see if this intervention did work, and what was it compared to? And maybe I just haven't seen it, but it's still been like an 0 for 3 experience of me digging just cursorily into Google Scholar to try to figure out whether some of these modalities are do what they purported to do, or if the proposed mechanism has even been tested to go beyond a proposal. Am I off base here, gentlemen? Can you help me out? This silly PhD sports science guy with your real educations, can you help me out, you allied health professionals?
I'm actually really excited you brought this up, because when Nick earlier was talking about a pathogen, I knew we'd go down a rabbit hole if I went here, but I have the opportunity now, so thank you, Eric. Nick was talking about pathogens earlier with disease. And the big problem here is pain, which is what most people are trying to solve or cure, is a symptom. It's not a cause. We haven't identified the pathogen. And in a lot of these moments, what we're trying to do, we use the human eye, we use many other things to observe. But like Nick's talking about pathogens, what do we use to identify pathogens? Microscopes, electron microscopes, really, really complex imaging type things that the human eye, which is horrible at pretty much anything, can't discern. So the issue is the actual causal link to pain we don't know enough about yet, outside of theoretical explanations behind what that pathogen is that causes the pain. So we can sit here and we can say it's fascia, or it's, deformation of tissue, or it's this, but then we get MRIs and we get imaging, or we open somebody up and there's no deformity and they're still in crippling pain. Nick and Jared can remind me of the actual story, the guy's name. He had a spike through his head and felt...
Phineas Gage?
Yeah, there you go. Thank you. Thank you for the reference. You would think, wow, that looks terrible. You should be in a lot of pain. None. So we encounter that a lot, where there's deformity in tissue and you would expect to see a large pain response, and it's not there, and vice versa. We have imaging, we have studies that show these people that have no deformation and are in debilitating pain. So we don't know the actual pathogen cause to relate the actual theory. So a lot of times you're going to go 0 for 3 because they're like, oh yeah, in class I learned, I stick this needle in and it has this effect on the tissue, and then that modulates the pain in this way. We don't actually know.
Mm.
And John, even if we did, right? So say in fairy tale world, even if we did have super diagnostic eyesight and we could identify the exact thing that is damaged, right? Quote unquote damaged, we don't have protocols to treat them. So if we have 5 people lined up in the clinic and they all have an identical partial tear in a rotator cuff, all 5 can present differently. All 5 will have different goals. Therefore, all 5 will have different treatments. It's not like again, my pathogen example. If you have people from across the world that have the same disease, hypothetically, it's going to be treated the same way. We don't have that, but I think we try to have that. So that's the thing. And I know we're back to treatment, but it's everyone is going to have a different treatment because everyone has different goals, right? So we don't have a supraspinatus tear protocol. We don't have a labral tear protocol. We don't have a herniated disc protocol.
You don't.
Everyone could,
but I've definitely seen them for purchase on the internet.
I stand corrected.
You just put here's the strategy. You put bulletproof in front of it, and then the body part, and then you make a PDF, and then $10. Again, I don't know why Nick hates capitalism. I mean, the coffee does that as well. That's actually the solution. That's the addendum to each PDF.
Capitalism.
I just wanted to kind of say that, and then so back to the modalities. Yeah, just like Jared said, I don't have a problem with them, as long as they are used appropriately, right? And as long as a narrative is correct and not misleading, right? So if we do all these things that we're talking about, we explain, like John said, hey, look, I know your MRI showed that you have this herniated disc. However, we know fairly well established in the literature that we can have these type of things. Anyone over the age of 35, 40 is going to have some of these changes, not necessarily a bad thing. And you probably have had this disc like that for maybe 10 years. So even though you have pain, it may not be related to that disc. Okay, we have that conversation. Now, the way that we treat this kind of thing, since we can agree that it's not the disc that we have to focus on to push back in place, now we have the conversation that how pain is multifactorial. It is the symptom, right? It's a perception. And we can do a lot of things to change that perception and change that pain response without changing your physical tissue. And then we have these checkpoints all along, and you make sure the patient is or the athlete is following along with you on this journey. And then once we do all that, and then once we explain, okay, I know your goal is to compete in bodybuilding, and your goal is to stimulate your quads for hypertrophy. Do you think instead of doing a barbell back squat, what if we do this instead? Or what if we modify this instead? Okay, cool. That's going to be our treatment. Different from person B, person C, person D. Did I miss a letter?
B? I don't know. I don't count that high.
Right. So now we have those big rocks in place. Those are the principles that we keep talking about, right? Now we have this treatment plan. Of course, we start by ruling out red flags, right? So anyone listening along, a red flag would be something like constant pain that can't be reproduced, can't be relieved, numbness, tingling, things like that. Pain that wakes you up at nighttime for no rhyme or reason. these kind of things, you want to go see a healthcare provider, get them checked out. But if this is pain that you feel with movement during the gym, like certain movements reproduce it, you can position your arm or leg a different way and it kind of feels a little better, but then it hurts again. That's the kind of pain that we're talking about here. So that aside, once we kind of go through that journey with the patient, now we're at the point, okay, we have this person in front of us or virtually, and they're in a fair amount of pain. Why not use something like a massage gun for 30 seconds or a foam roller for 30 seconds to kind of decrease that pain response? Now that opens the door for us, at least in the short term, to start doing the big rocks, to start loading that squatting pattern, to start loading that overhead movement pattern, right? Manual therapy, same thing. Like, I'm not sitting down massaging someone for a half hour, but if I press on a muscle and it makes them feel better for 30 seconds, and then they can go load that tissue appropriately, that's 30 seconds well spent in my mind, as long as it's sandwiched with the narrative, hey, I'm going to try this technique on you. It's not going to change your tissue. It's not going to realign anything in your body. All it's going to do is it's going to kind of change your body's like perception of like overall sensation. It's going to help decrease that pain a little bit in the short term. Then we're going to follow it with a 1-2 punch of some loading, and then we're going to put some ice on it afterwards, maybe just to calm it down afterwards. But at least they know that the important things are not my hands, are not the foam roller, not the massage gun. We've gone through that journey with them, and then we've kind of put like that sprinkle on top. Oh, by the way, this can help if it tends to get flared up, and none of these other strategies seem to be helping, at least in the short term.
Yeah. And I want to clarify too, because, one of the things, you get these camps, especially in the rehab world, where when there's the discussion around how it's not a one-to-one relationship between tissues being X and then pain being Y, and how pain is multifactorial. The rebut, the caricature often is like, oh, you just talk to your patients and make them feel better. That's not usually how it goes. And we're not saying, John, Nick, jump in if you disagree, but we're not saying that if your quad ruptures, it's not going to be painful. It probably will. My money's on it not feeling good. Or you get a spike through your head, it's not going to be painful. Probably will. Probably want to reconsider life decisions that put you in that situation in the first place, but that's beside the point. But what we are saying is that there's a lot of nuance. It's another word that kind of gets memed these days, and it still comes back in my mind to, what do I do? Both as a clinician or a coach, working with people who are in pain, trying to help them out. People, that's usually where people's hearts are. I want to try to help them get where they want to go. Or as a person in pain, as an athlete, trying to just do the things that they care about. And for me, it comes back to starting off with a relationship, professional relationship that allows for the person as coach or clinician to really understand, to take the time to hear that person's story, understand where they're coming from, where they want to go, and where they are right now, what matters to them, what they think about the situation. What do they think is wrong? What do they think needs to happen to get them where they want to go? And then ask for permission to engage in a conversation of like, hey, cool, I hear you saying this. Here's what we see in the research. Here's what I think is going to really help you here. Does that make sense? Do you want to try that together? And again, being able to still use modalities if you want. Like I don't work in the clinic anymore, but when I did, I would use manual therapy sometimes because some people felt really good with it. Before I train, I'll usually grab a foam roller, I'll crack my upper back, and I'll roll up my hips. And then I'll do my other stuff because that is worth it to me, where it helps me feel looser. And it also then allows me to focus more on the thing that actually creates the change, the actual training. So again, that's why the context matters so much. Understanding where the person wants to go, and then giving them the information of, hey, here's what we know, here's what we don't know, but here's what I see being important for you. Does that make sense? What do you think? And then it's that journey together, which again can sound woo-woo, but I really think it's the foundation of this, or doing this well with people.
That's really helpful. I think once again, my statistics piss poor knowledge that exists, but is not great compared to real statisticians, might be helpful here. And there's, I think, two concepts which might be helpful for anyone who is one of those folks who would rebut maybe what you're saying, or someone who's like, hey, I have an issue, I do this, I feel better, or my patients feel better. So what's the deal? Why the modality hate, y'all? And there's two concepts that I think are worth bringing up. One is the recency bias, and the other is regression to the mean, and understanding how those interact. And I'll put forth kind of my understanding of how I think this probably plays out, not being a clinician, but understanding these concepts. And then I'd love to hear your guys' thoughts. So regression to the mean, while there is an actual straight up just mathematical understanding of this, there is a important relevance to biological systems, which strive towards homeostasis. So if you were to get sick, most of the time, assuming it's not a fatal disease, you're going to get better. And a treatment for one of these non-fatal or non-untreatable diseases is something that might reduce symptomology while you follow that natural progression towards getting back to homeostasis and not having that disease anymore, or it being manageable, or potentially speeding up that process, improving your immune response, healing, what have you, reducing inflammation during it so you don't feel as shitty, et cetera, et cetera, et cetera. But the important thing is, even without that intervention, you would have gotten back to where you are. Okay. So you can imagine in that same scenario, if you were then to use something that had no effect, no objective effect outside of the placebo, that you would have, I am now sick, I have now intervened, and I'm eventually better within a relatively short time period. And you could therefore, because of what's called the recency bias, whereas we as humans, we make associations. That's why we're still alive today. We can learn from our actions, and we figure out how to survive and make better decisions most of the time based upon these things. So the recency bias, we connect the most recent thing to the thing that immediately preceded it, right? So, just an example of if you had a meal and then you had diarrhea right afterwards, you're thinking that the meal I just had is what caused my diarrhea. And while that might be true, there might have been something that irritated your stomach and resulted in that. What you're actually pooping out is the last meal before that because of the time course of digestion. So you're thinking they've got to be the same thing. And sometimes we lose our objectivity. And I don't know why I chose diarrhea as the example there, but I think it illustrates the point. We can make false associations. So if you did X, then X actually has no evidence behind it, and you were having a natural time course towards healing anyway. Therefore, as a clinician or as someone receiving treatment, you can start to make these false associations. And I think in a scientific sense, if we really wanted to know something works, we need to have a placebo control. Because like you guys said, confidence matters, and that's basically giving someone positive expectations. And in addition, you need to be comparing it to something else, like what is the standard care? Is this even worth doing? Is it providing anything beyond the placebo effect? Because we can't just show that it just beats out placebo. Like, what are other options? What's standard if it exists? So, am I getting that right? Is that something that's relevant to y'all? And what are your thoughts on it?
Yeah, I think you're 100% right. When it comes to some of this stuff, one kind of thing I want to introduce here is ego. When it comes to recency bias and it comes to regression to the mean, it's really cool. Like whether you're the person experiencing it or whether you're the clinician doing it, when you have that intervention and it works, right? There's a level of control that we feel over that, regardless of whether we're the clinician or the one being treated. And that in and of itself can really bias a lot of these things. The fact that we're actually not in a lot of control, that Mother Nature actually has a lot to do with this stuff, is a hard thing for people to close the dissonance on and close that gap, right? So that's why it's super easy to be like, yeah, I just changed the oil in my Toyota Camry. It's good for another 10,000 miles. Where it's easy for us to have that control when we get injured and we just kind of let it take its course over the next 6 weeks and manage it and understand that we're not in control of this entire experience. That's a hit to our own ego. And one of the reasons why that search is real, because that's what recency bias and those sorts of things, they feed it. They feed the ego. They feed that immediate gratification. You get that big fat dopamine hit and you're like, I solved that shit. And you get super pumped. and it's not real. That's hard to cope with.
Yeah, I think this kind of goes back to the fact how I kind of compare it to cancer research, where I think on a past episode, I forget which one it was, but something was compared to like rocket science, and the reason why the recency bias exists and why regression to the mean can impact these things is because, like we said, pain and injury is this murky area, and it kind of gets better on its own. That's why all of these different screens and assessments and this paradigm to optimize movement and then treat the dysfunction. That's why these things exist, because things kind of get better, like we keep talking about. If pain was something like cancer, or pain was something as solid as like rocket science, like okay, we got to put this rocket in orbit at this exact time so that these like 500 steps take place, and then this flying rock in the atmosphere hits it at the exact right time. Like, there is no room for these screens and things that we're talking about. If pain and injury management was like cancer or was like rocket science, all of these things that we're talking about would not exist. The problem is that people get better regardless of what we do. And like John said, there's that dopamine hit, and it builds our confidence. It builds the patient's confidence in us. So I think you guys hit the nail on the head with that. And I think that's part of the reason why we're having this conversation, is because things just kind of work. And if the stakes were higher, these things would not exist, or they would be highly, highly, highly unethical to exist.
Nick, I can't help but think that it's partially also a two-way street, as Eric would say, in the sense that the three of you are well-intentioned. You want your patients to feel better. You want them to, myself and Eric, we just see dollar signs when we see humans. But so there's maybe two different schools of thought. We'll let you in on the Masculinity Crisis tour afterwards. But let's assume even the person is well-intentioned. On the flip side, because I heard Jared, I heard John talk about, the powerlifting base, or like a competitive clientele where they have their identity tethered to that. So it's that two-way street where you want to produce a result for them, maybe to feel better about yourself, but also to see them get back to where they are. So you have an incentive, not financial, but let's say emotional. They certainly do. And it's almost like this feedback loop. When John mentioned Ricky Bobby, I'm going to quote another Ricky Bobby quote here. If you ain't first, you're last. And that's that mentality. I can attest to this, and I can say, Eric, where it kind of feeds into the other, and maybe the practitioners that identify the problem in the space is that these people are looking for a solution. So giving a framework of understanding, even if it's not tethered to reality, gives some sense of assurance that they're moving in some sort of direction. So it's, of course, it's a bunch of BS. We're really just shelling out bullshit here. But when you experience that, like what you said, Jared, about the hamstring injury, for myself, the identity being tethered to something, and when John brought it up, I was a terrible weightlifter. I felt bad because when you said motor learning, John, I was like, bro, I might be the worst example, because it's like this Rocky story where you start, I was like, yeah, it looked cringe, and then we could finish on like the high note. Yeah, and he cleaned like 140 kgs, competed at nationals and placed third. I'm like, I didn't really get better. It's like, I wish I could, but the truth is that separation, I think when you talk about the three of you, the time course, some of the common ground that I'm hearing and internalizing, I think the audience can perhaps relate, is that their expectation of when they want something quote unquote fixed and the reality of what might happen, they're two different time courses. And that's the very first hard thing to swallow, where the number one mistake I made when I had, an acute injury that happened, and then I just try to get over, because I'm like, I've had this happen before. I went on the bandwagon immediately. Envelope of function, don't worry about it, bro. Like, I could just work through this. Like, desensitizing the pain. Anyways, moving forward. And that sheer desire, because I was getting, you want to talk ego, John, I was getting that ego being fed of like, I'm getting stronger. This is the reward mechanism for me. So managing, in addition to the right interventions and the right expectations, understanding where the clientele is. When you said, both of you talking about powerlifters, that seismic shift, while I was a terrible weightlifter, and side note here, Eric, I must say, the weightlifting community, my heart will always be, as soon as I saw John and he's like, I'm a powerlifter, I'm like, I already feel kinship. It just seems like a jovial fellow. Like, we're going to lift, we're going to squat. You look like you squat big weight, man. Some of the weightlifters, I said, man, I think I'm going to suck at this shit. I'm interested in doing it, da da da. And it was their opportunity to mog on someone was like, oh, he thinks he fucking sucks. I'm like, yeah, I said I was gonna suck. It was just a very interesting like internet space where it's like, bro, I'm trying to be open. Like, let's have this crossways. Like, I come from this position, this and that. And that's why I do have to give a shout out to the powerlifters because they opened their arms right back up. Where I came back, it was like that. You move on from a relationship because I had to. I was in a bad place. So I tried something different. I did the pivot. And then I realized that wasn't my thing. My pain was desensitized enough where, hey, I could squat again. Oh, I hit a deadlift PR, I hit a squat PR, I hit a bench PR. And damn, did it feel good. But that whole time, the community around was kind of like the friends in the relationship of your significant other. Like, they're like, you shouldn't be with him. Like, he sucks. Like, what are you doing here? But that was the time course. Had I had known you fellas at that time, it would have been drastically shortened. And I think that is something that the three of you, from what I've heard, are certainly addressing. And that's a tough part because you have something happen, you want the solution. And oftentimes I see where the opportunity comes, is what I'm saying, for these practitioners to give a false sense of confidence because of the regression to the mean, the time course that will eventually solve itself, them therefore having a belief that there is a framework to move forward, as opposed to like, you guys sit in this for a bit, man. It might be 12 weeks hamstring tear, 16 weeks out, like, it's going to take a while. And I've experienced that firsthand, and I can't help but feel that for a lot of people, there's a certain uneasy, even when listening to the first hour of, FMS like screenings. It's a cool story, guys. Like, yeah, it's not helpful, but what do I do? Like, I can't have like the powerlifter and me thinking like, but what do I do? Like, okay, well, what's up my shoulder? What do I do? And so I do think like it's a much tougher road, what you guys are describing, but I commend you highly from being on that other side and basically doing everything, what I'd say textbook wise wrong, to try and get over it and then learning the hard way.
All I can think is that each of the primary three barbell communities creates a different type of dysfunctional relationship with people. So we got weightlifters, we got powerlifters, we got bodybuilders, each one of them. So we've kind of touched on weightlifters. They're basically the I don't want no scrubs, way too high standards, and just immediately neg you. Like, oh, I'd like to join your community. It's like, well, can you already do a perfect snatch? You're not part of the community, and I don't actually want you in my gym. It's like, well, how did you guys ever learn to snatch? Shut up. Get out, Powerlifters, like you said, they take everyone, welcome with open arms, and they're kind of like the friend who, even when you're doing the wrong thing, they got your back, It's like, I can't believe he treated me this way. Like, didn't you cheat on him? Yeah, but no, you're good, honey. He's the shit. He's terrible, And they will just constantly enable you into being your worst self. And everyone has tight hips together, and that's all good. And then bodybuilding is the dysfunctional relationship where initially it's welcoming, but they then constantly tell you you're not good enough and you have to be better. And you can never actually be good enough, but you're definitely welcome. Come back and do another show. So there's no winning, folks. But the good news is you can get injuries from all of them, and then you can seek out these gentlemen to help you get back on track.
Shoot, silver lining if I've ever have seen one.
That's right. Well, geez, gentlemen, we've covered a lot of ground. We kind of had 3 points to this roundtable. One is the issue with some of the actual testing protocols. 2, the issues with some of the interventions that especially when they're tied to these testing protocols. And then the third aspect is really kind of going right back to the first one. That's retesting, which I think we actually already covered pretty well, knowing that there is that motor learning aspect. And again, it is just the administration of the same test that you've been practicing that's not actually related to the thing that you may not actually have that you got assessed with a thing that doesn't assess anything. So it all goes nicely together. And I think we covered a lot of ground, but I am not the expert. So what I want to do now is open the floor to the three of you gentlemen. Is there any nuances, key terminology for this podcast, folks, that you feel we have not covered or circles you want to square before we close this one out?
I just want to say we've said nuance at least 2 or 3 times, so Jordan Feigenbaum is smiling somewhere. You may not know why.
On a golf course.
Yes, this is for you, buddy. So, I mean, for me, because again, we've come back to the question of what do I do a bunch of times. So if somebody's listening to this and wondering that, if you're in a spot where you could use some help, look for some professional who occupies a space that makes you think they could maybe help you. My go-to is just reach out to them and ask to talk first. Because in my experience, the people who are worth their salt and who really care about That's not the way to say it, because I do think people's hearts are generally in a good spot. But the people who are really good at helping a particular population, bodybuilders, powerlifters, CrossFitters, whomever, they want to make sure they're fit for you as much as you're fit for them. So it's been my experience that the people who check those boxes are willing to talk to you, even just for a few minutes, to hear where you're at and say, "Yep, I think I can help. Let's talk more, or let's set this up." So just reach out, and it goes a long way. If you're a coach or a clinician, if you aren't the person that somebody needs right now, tell them that. I've done that a bunch, where I'm not the guy. I'm not as good with XYZ, but I know Nick, or I know John, or I know whomever, who I think would be a better fit. Is that cool if I put you in touch with them? So that's what I really think helps a lot on both sides of the professional relationship there.
I think one of the main points, Jared, that's really well said. I can't agree more. I think one of the main points that I don't know if we actually mentioned, but I think we all feel, is that we're not here saying we have the answers. We're not here saying that we have figured it out and everyone else is wrong. We're saying we know what we don't know, or at least we try to think what we don't know. We try to think about what we don't know. And I know there's plenty of people out there who have success with these different camps that kind of fall into this conversation. And we're not saying that you're silly or stupid or you've been bamboozled because you have subscribed to a certain kind of camp and have had success with it, and enjoy it, right? If it speaks to you and the leaders of that camp, like, you just kind of jive with, and things have been going well and you're getting better and you're meeting your goals, keep doing it. Like, we're not saying to run for the hills if you notice anything like this. Just consider that you may be getting better despite some of the things that you're doing. And just because you're getting better from a certain path doesn't mean that everyone else is going to have the same response. Just like a nutrition plan. If you do great on keto or do great with intermittent fasting, that's great. That's fantastic. Keep doing what you're doing. If it's easy to adhere to, you're enjoying it, great. But it doesn't mean that everyone else has to do that if they want to lose weight. So I just want to leave it with that we're not here telling other people that they don't know what they're doing and need to listen to us. We're just trying to show these are some principles of injury reduction and management. And there are many, many ways to get to the point of reaching your goals. And whatever path that is easiest for you to adhere to, whatever one that you feel most comfortable with, keep doing it. Just understand that there are many different options out there.
My nuance is going to be real simple. If it sounds too good to be true, and it sounds overly complicated, if it walks like a duck and it quacks like a duck, it's probably a duck. Period. I just steer clear of that shit. Don't worry about being WOTA.
We don't mess with ducks here in Iron Culture. No.
No ducks. I don't want no scrubs.
I don't want no ducks. Ducks are the ducks that quack at me too much. I don't know. So, folks, I really appreciate your time and energy, and I think people are going to want to reach out because people have problems, and you just admitted that you don't know the solutions, but you can admit that you don't know the solutions, unlike some of the folks who will bamboozle them, like those ducks quacking at their heels trying to get those dollar bills, y'all. So, folks, where can people find you? Nick, where can people find you?
So people can find me, 3dmusclejourney.com is a good place to find me. My Instagram as well, at Nick Licameli. At any of those platforms is totally fine. And I think one thing we learned also from Omar's brother is if you're injured, don't fret. It'll all work out.
Jared, where can we find you?
Instagram is probably the best place, jared.unbreakablestrength. I'm an open book. Yeah, if anybody has questions, they want to just fangirl over Omar's ancient workout videos with me, open invite. So feel free, shoot me a DM. But yeah, that'd be the best place.
Awesome. Well, once you get done with the Ancient Workouts watch party with Jared, then I want you to hit up my man John. And John, where can they find you?
Rebuild_stronger on Instagram. That's pretty much the only place I am. We talked a lot about data, talking about the ancient workouts. I would love to know how many more Spartan and ancient Greek references have been on the show since the History Channel release. Like, I feel like that's exponentially increased. I want to see a curve.
On Iron Culture?
Yeah.
Yeah, we're not subtle with our references. Like, there's just direct call outs, and we wait. Even though we don't have the immediate feedback from the audience because we record this, then release it, we'll wait. We'll wait for them.
Yeah, subtlety isn't what we do, and we don't need data. We just have our finger on the pulse of what the cult wants, because when you dictate what the cult wants, you by default know what the cult wants. And folks, I know what the cult wanted for this episode. And they wanted you three beautiful men. So thank you so much. I think this was a fantastic episode. I think we covered a lot of ground. We filled in a lot of holes, giggity, from the last few episodes that we had on this topic. And I hope now, for those who have issues, pain, injury, recurring problems, and you're on the precipice of these rabbit holes, that between the prior episodes and this one, you can turn around and embrace the unknown, but still have the confidence that, yes, it will be all right.
Just Eric, hunks being hunky. I can't aspire to be in any higher of a position. Fortunately for us, I will say, Eric, we can, because we're atop the pyramid. And if you're looking for the absolute answers to everything, we got them for you. Masculinity in Crisis. Nick is competing at the Muscle Mayhem, which conveniently will be actually right down the street from our pavilion, where myself and Eric will be giving one of the first of many lectures of the Masculinity in Crisis. So stay tuned. Look, we're the top link. Then these three hunks, please check them out. You can go ahead and also leave a rating and review. Folks, we like to keep it open-ended. We like to consider ourselves open-minded individuals. However, most people leave 5 stars, and you could, try and be your own independent self and leave something different. But you've heard that phrase, regression to the mean. Well, I'm going to give you another one. Do what you're told. And so 5 stars is pretty much the right number one should get. And as Nick said, don't fret about anything because they have the solutions. Go ahead and contact them, please, down below. And as for the Iron Cult, well, I'm glad you asked that. We're back every single Monday from now until the end of time. We'll catch you in that next one.